Right there. Sorry, that's our lateral. All right. You've done a nice job. So one thing I can tell you about this patient, as I said before, is that the worst disc injuries are at L3-4, L4-5, and then L2-3. Yeah, I guess we'll wait. The L5-S1 does have a disc injury. It's got an annular tear, and there's a what's called a bulging disc, okay? Many of you have heard of bulging discs before. Bulging discs can be very painful. And so this patient has back pain. I believe she has pain coming from that bulging disc. So we don't want to not treat it and have her end up, you know, having pain, Sean, after she leaves at the L5-S1. It's important that we fix everything that we can here today while we're doing the surgery. All right, AP. So I know I have to fix 4 discs today, L2, 3, L3, 4, L4, 5, L5-S1. I'm going to try to do it with 1 incision on the skin, 1 entry point. That's really nice. Go back to a lateral. And because I'm fixing 4 damaged discs, I have really 4 targets that I have to get to. So even though my starting point is the same, theoretically with 1 incision, I have 4 targets to get to. Are you comfortable? All right. Where do you feel that? Sir? Yeah, in your back, right? All right, lay still. You're doing really good. Everything's going fine. All right. Shot. Have to go a little bit higher up. Shot. Yeah. Shot. So this is the L5-S1. Of all 4 discs we're fixing today, this is the most normal when it comes to the height of the disc, the appearance on the MRI, etc. But I believe this is a painful disc. How do I believe that? Well, I looked at the MRI and I saw that there is a tear in the back of the annulus, posterior annular tear, and then that tear is has jelly in it, nucleus pulposus, and that we call the jelly that is stuck. You can stay there for now. We call the jelly that is stuck in there interposed nucleus pulposus. Okay, we're making our incision. Are you comfortable? She doesn't feel it because we numbed her up appropriately. But it's a 7 millimeter incision, okay? And like I said before, we're gonna try to do everything with just 1 incision, okay? Hopefully that's gonna do it, but we'll see. It just depends on your alignment. Right now, it's looking promising. The alignment of the spine, that is, the alignment of the discs. Sean? There is a considerable amount of arthritis here at the next level. Now, I think we're okay on the side view. I'm looking at the pedicle of L3, I'm sorry, the pedicle of L4 and L5. And they appear to be lined up quite nicely on the lateral view. And that's important that you look at that. Shot? Shot? I'm a little concerned that we're not going to be able to get all the discs done with 1 incision. Shot? Only because I have to get much higher. I think we're going to have to do 2 7 millimeter incisions. Shot? But everything's going very well right now, okay? Just to give you an update. You're doing fantastic. Where do you feel that? In the back? Yeah, that's what we would expect. Just lay still. You're doing really good. Almost done there. Shot. Yeah, try not to move, okay? You're doing great, by the way. Try to relax. Shot. Yeah. She's definitely not relaxed. Shot. Anything you can do to help me out? You're doing great. Don't worry. Everything is fine. Shot. Let me try again. There we go. Much better. So the first stage of this type of surgery is to create a path from the outside world here to the problem area, which is the annular tear in the back of the disc with the herniation. And the surgery you're watching is very unique in the sense that it's the first surgery in the world to target the annular tear in the back of the disc. There is no other surgery in the world that does that. And that's why it carries the name Duke Laser Disc Repair, because we're the first ones in the world to do this type of surgery. I'm thinking we're going to need to start a little higher. Let me know if it's uncomfortable at all, okay? Just say ouch. That way I can give you some more numbing medicine. Okay, I just need to know if you're feeling uncomfortable. Shot. So the goal is going to be to access the discs with the needle without creating discomfort for the patient. Too much discomfort. Obviously there will be a little bit. But you can't give numbing medicine down by the neuroforamen. Okay? If you give numbing medicine down by the neuroforamen, the patient could lose feeling in their leg. Just lay still. You're doing great. We're almost done, and I'm going to put you to sleep in about 10 minutes, okay? Maybe less. You can actually see the herniation on the x-ray at L3-4. It's huge. It's in the foramen. Shot. I'm heading right towards it. And that's my goal, is to get to that herniation and remove it. So the surgery does remove herniations, but it really also, the main purpose of the surgery is to clean up the tear in the back of the disc. I mean, it's a thick herniation. Sometimes I get very lucky, and I thank God for that. That's a seriously collapsed disc. And even though it's, so people wonder, does this surgery work for degenerated discs? Degenerated discs are no different than a herniated disc. All degenerated discs start with a herniation, and all herniations start with an annular tear. They all start with an annular tear. Okay? Every tree on earth starts with a seed. The seed is small, and it becomes a tree. If it's lucky, it survives and becomes a tree. Okay? And to get to the tree, you first have to have a seed. Now, sometimes branches fall off, and they end up rooting and surviving and growing into a tree. There's a second way of it happening. All right? But when it comes to herniated discs in the back or neck or thoracic, they all start with a tear. The tear is the first insult to the disc from a normal disc to become a herniated disc or even a degenerated disc down the line. you start with a tear in the back of the disc. Are you comfortable? All right, we're almost done. I promise you. You're doing fantastic, by the way. Really, you are. Honestly, you're doing really, really good. I'm very proud of you. You're laying still. You're doing fantastic. So I'm hoping we're going to be able to put you to sleep very soon, okay? Sean, do we have any questions?
None currently.
All right. So years ago, we're going to go to 2-3 now. That's the upper one. So 5-1, 4-5. We currently have a needle in 5-1, 4-5, 3-4. Next is 2-3. But before I go too much further, I need to make sure that my map that I'm using is accurate. And the map accuracy changes throughout the procedure. So it's up to the surgeon to ensure the map is accurate. And right now with that lateral x-ray, it's not accurate. We need to get the pedicles of L2 and L3 lined up. So what I'm using to navigate are the bones. And we talked about this during the last, 2 weeks ago, during the last surgeries I did, is the bones are like stars. You navigate from the stars many years ago. Now we use GPS, right? But in the old days, the sailors, they used landmarks. They used, rocks sticking out of the water. They used bays. They used mountain ridges. And they used stars. Did you reposition the fluoro? So in spine surgery, we use the bones of the spine to navigate. And that's true no matter what shot. I think it's going to be let me have the WAG feature. You think that my side needs to be further north or south? Yeah, that doesn't look right. Shot? That may be worse. I don't know. That looks better. There. Shot. All right, that's it. Lock it in. Okay. So what I did was I wagged the fluoro. The fluoro is an X-ray machine. It emits an X-ray from an X-ray beam from here, the emitter. That X-ray beam scatters out, as it leaves the point source where the X-ray comes out of, and then it goes through the patient, and then it hits the detector panel over there on the other side. And depending on the density of the tissue the beam is penetrating, it gives you an image. Anyway, we need to make sure the image we're looking at is accurate. All right, just lay still. You're doing fine, okay? Lay still. I'm going to give you some more numbing medicine. So we've got 3 out of 4 of these needles in place, okay? Did you watch the surgery, you said? All right. So far we've had literally maybe 2 or 3 drops of blood. Okay? You're doing fantastic. Everything is going really well. We're almost done placing these things. And then I'm going to be able to put you to sleep in a little bit, okay? Shot. I'm a little bit lower than I want to be. Shot. Shot. I'm getting caught up on the facet joint, which is fine. I just have to navigate around it. Shot. Shot. Now the reason we're having trouble is that the facet joint itself is enlarged. It's what we call hypertrophied. And the reason it's enlarged, let me have the skin knife. The reason it's enlarged is from arthritis of the joint. Thank you for doing that. It's the arthritis of the joint that causes the joint to enlarge over time. This patient's had back pain for over 20 years. So her disc injuries are over 20 years old. And when the disc itself is damaged, what happens next is the facet joints become loaded abnormally. Okay, what that means is when the disc is damaged, like a herniated disc, it causes her body to shift in its balance as she's walking and standing and doing things, and that causes that causes other joints to wear unevenly, specifically the facet joints. They're a type of joint, and they're in the spine, and they're really in the back of the spine, behind the disc, and her facet joints are extremely arthritic. So, all right. Now we are hopefully done with positioning. I had to do 2 incisions, which is fine. And that's because her spine is so straight. If she had a nice curve to her spine, a normal lordotic curve, then all those discs would come out pointing to pretty much the same spot on the skin surface. So I could have had 1 entry point, but I'm not going to compromise the results of the surgery just to have 1 incision. That's foolish. That would be cutting off your nose to spite your face. So really, the main goal is you're fixing the disc, so sometimes you can't do it through 1 incision, you have to do 2. Are you comfortable? All right, we're about ready to put you to sleep. You've gotten through the beginning of the surgery, but I need to test a few things, okay? Don't get upset with me. Just lay still. I'm going to ask you a question in just a minute. I want you to be able to rate your pain on a scale of 1 to 10, 10 being the worst pain, okay? How bad is that on a scale of 1 to 10? I see a huge tear at L23. How bad did that get on a scale of 1 to 10? I need a number. What's the highest it went? 9.5? All right, L23, 9.5. I'm sorry about that. But that was your L23 disc. Is that your typical pain you get every day? Is that the same location? Yes? Yeah. It may not be that bad because you guard yourself every day, but that's the right location, right? Yeah. So I knew when I examined this patient, even though she had 4 discs that were herniated with annular tears and bulging out, I know exactly where those discs are on her body topographically, like on the skin. I know where they should be. And when I examined her and talked to her in clinic, I realized that she didn't have pain just from 1 or 2. It looked like she had pain from all 4. So just to give you an idea of what I'm talking about, I'm going to draw, and you're going to be able to see this when you're done with your surgery, okay? This is the L5S1 disc right here. And she has a tear and a herniation in the back right there. And then we have the L45 disc, which is right about here. Okay, that's L45. And again, a tear with a herniation. And then she's got her 3-4 disc, L3-4 disc there, and her L2-3 disc here. Okay? So if I were to look at a patient's body and their back, the belt line runs right about here normally, but right between L45 disc and L5S1 disc, okay? Now between these discs are bones. There's one bone there, okay? I'm gonna make the bones look like that. This is gonna be good for you. You get to watch this later and learn about your problem, okay? Huh? What'd she say? All right. L34, L2. We're going to put you to sleep in just a minute. I just got to finish the tests. All right, so we tested the L23 disc right here. And this disc was, 9.5. We're going to round it up. We're going to call it a 10 over 10. Because we don't do 9.5s. We round up, and rounding up 9.5 is to 10, okay? So we already know that that disc at the top, where she showed me, oh, I have pain all the way up here, all the way down to here. So we know that that disc is now a 10 out of 10 pain on the discogram. You're fine, lay still. We're almost done. We're going to put you to sleep. How bad is that on a scale of 1 to 10? Huh? I can't hear. 10? All right. So that was a 10 out of 10. I'm sorry. We're just testing the disc to make sure we're doing the right thing for you. And absolutely it is. These discs are causing your back pain. You had back pain 22 years. That pain will be gone when you wake up. Because the Duke Laser Disc Repair will fix your discs without fusion, without metal, with just 2 7mm incisions. You okay? How bad is that on a scale of 1 to 10? 10? So you got a 10, 10, 10. So this is another 10 out of 10, folks. So far, we've gotten 3 10 out of 10s. And if you look at the discs on the x-ray, Sean, have you flipped over to the x-ray views at all?
Yes, they can see it.
You can see the black dye in the disc between the bones. And most importantly, you can see that the dye leaks out through the back. That's where the herniation is. That's where the tear is, the annular tear. Posterior means in the back. So it's a posterior annular tear with a herniated disc, or the jelly from the center is squeezed out through there. Okay? So we are going to fix the tear and the herniation. That will get rid of her back pain that she has now from these discs for the rest of her life. And she also had left leg pain. Are you comfortable? All right. Did you move the fluoro? I'm not really able to get anything. Come south, shot. All right, good. Are you comfortable? Nothing there. So she healed the tear. All right, so that's a question mark. Not any pain there? All right. I'm going to leave that one alone. We tested L5S1 and there's no pain. No pain at all, right?
Any pain with that one?
No. So we're going to put a no there. I'm going to leave that there for now while I think about what to do. I'm going to look back at her MRI. Right now it looks like there's no stenosis at L5S1. Yeah. So we're going to not do that one right now. We're going to wait. But I'm thinking based on the fact there was no pain. And by the way, for those of you who don't know what a discogram is, it's a test where we test the discs that are damaged to see if there's pain generated from them, the patient's typical pain. And you just saw I injected and there was no pain. So some people think, well, every discogram causes pain. No, it doesn't actually. All right, we're going to put you to sleep, okay? When you wake up, we'll be done with your surgery. I want you to count from 1 to 100 out loud. Just lay still. All right, shot. So at this point, we are done with the evocative discogram. Did you do a shot or not? There we go. So I've tested the discs that on the MRI appear abnormal. I've tested the discs with the discogram to see whether or not they're actually causing her pain. And in her case, 3 of the discs, L23, L34, L45, are causing her back pain that she has every day, based on the discogram results. L5S1 is not. And I said at the beginning of the surgery, L5S1 was a small tear with a bulge. And in this case, I don't believe it's causing her pain. That's why we left it alone. Shot? All right. So we've got our guide wire in place. We're going to take our needle out. Leave the guide wire. Shot? I need some irrigation on my fingertip. Now this patient has a tear in the front of her disc as well. And you can see the guide wire at the front of the disc. It's not going out past it, but it's definitely there. And the fact of the matter is we never repair annular tears in the front or sides of the disc. Why? Because they don't cause pain. They don't cause pain. Only the annular tears in the back of the disc cause pain. And that is something Duke Spine Institute discovered, and we've talked about it many times. Shot? All right, so now we are at L45 with the dilator, and we're going to enter this disc, and we're going to basically repair the annular tear and remove the herniation that's there. Once again, we're live streaming, Shot, the surgery around the world for free as part of Duke Spine Institute's commitment to research, education, and educating the public. We don't charge for our streams. You're doing great. Shot. Shot. All right, at this point I can remove the guide wire. I don't want to trap it and pinch it in there. And we can advance, Shot, the dilator as far as I want it to go, which is usually 2/3 of the way. And there's something else happening here which is really to the benefit of the patient and the surgery. By the way, we've lost about 3 drops of blood so far. I don't expect to lose much more. It's typical for the Duke laser disc repair surgery you're watching. It's outpatient. We are not at the hospital. We're at Duke Spine Institute. We're an ambulatory surgery center, basically, and we perform all of our surgeries outpatient, including fusion surgeries that we do when we do them. We no longer take surgeries to the hospital for spine, Shot. Everything is done outpatient. All right, we're going to move the fluoro out of the way, and we're going to get started with the laser part of the surgery, the endoscopic surgery. So fluoro is out. We have a tube now. It's called a tubular retractor. That is, yeah, you need to go out. Good. That's probably good. Just watch out for that. You don't want to get anywhere near there. You're fine where you are. Luis has room. What? Yeah, I see the monitor. Yep, thank you for asking. All right, so our tube is in, and now I'm going to attach the suction line. Can you see this, Sean, or do you need some light on?
We can see it.
Okay. All right. So let's turn the light on for a moment and look at the endoscopic rig. Sean, can you see the rig?
Yes, we can.
Endoscopic surgeons call this whole thing the endoscopic rig. And obviously it's made up of a few different components. The camera, which you may or may not know, it detaches here, and then the endoscope here. You have a light source, right, which provides very bright light with a fiber optic system down to the end of the scope so we can see what's at the end here. You also have irrigation, which we're going to turn on. And then you have what's called the working channel, this channel here where the surgeon can introduce things down to the end of the endoscope. Now we're inside this is going to be the L45 disc. This is one that had a big herniation. And we are going to remove this herniation from the inside out. The inside out technique is a technique that Dr. Anthony Young taught me and he developed. And I've talked about it many times before, where you start inside the disc and work your way out into the foramen. It's much safer than going outside in, where you start in the foramen and work your way into the disc. Now, endoscopic spine surgeons are few and far between. There's not many of us. Can you move the IV pole a little bit? It's like right in the middle of the screen. Yeah, it's pretty good right there. Okay. So endoscopic spine surgeons were few and far between, but we all do our endoscopic surgeries differently. There's little differences. But when you're talking about a little surgery in a little hole, little differences can become big differences, and they actually are. And the type of surgery I do, the Duke laser disc repair, is different than other types of endoscopic surgery. And the biggest difference compared to other transforaminal endoscopic surgeons that use a similar approach and a similar equipment is that I do what's called an annular debridement. Annular debridement. That is the magic. And the Duke laser disc repair is the only surgery in the world that does an annular debridement. So if you go and have endoscopic surgery done elsewhere, that's a piece of herniation, by the way, that was pushed back into the disc when I put the dilator in. I used to wonder how the herniations got back in the disc, and then it became obvious to me that when I'm pushing the dilator through the tear and the herniation, it's reducing the herniation back to the disc, which is wonderful. And that was the advantage I was telling you about earlier of the treatment that we're doing. Other types of spine surgery, they don't do that. So if you do a microdiscectomy, the herniation stays right underneath the nerve root the whole surgery until you remove it directly from the nerve root. But with endoscopic surgery like this, we actually reduce the herniation, which is a standard treatment in disc surgery. If you're doing a microdiscectomy, you want to get under the nerve root with what's called a curette, and it's a reverse curette, so you're going backwards with it, and you actually push the herniations back into the disc, and then you safely remove them from the disc. So the concept of reducing a herniated disc that's in the foramen or epidural area, central canal, etc., back into the disc through the tear, and then removing it with the pituitary rongeur, removing the herniations with the pituitary rongeur from the disc, center of the disc itself, that is not novel to my treatment, my technique. That's something I learned in residency. But the idea of doing a debridement of the annulus, that is what I created, what I've contributed to spine surgery. And it's probably going to be my most significant contribution in my lifetime, besides doing outpatient spinal fusions and really moving spine surgery to the outpatient arena. But I was not the first to do spine surgery in the outpatient arena. There were many of those before me. When I say many, I mean probably about 20 surgeons that got there before me. One of them being Dr. Anthony Young in Phoenix, Arizona. He started doing outpatient spine surgery with endoscopic transforaminal approach, similar to what I do, but not the same. He started doing that back in the 80s, I believe. So he's a true pioneer of outpatient spine surgery. So is Dr. Alfred Bonatti. Unfortunately, I'm not going to say anything negative about Dr. Bonatti, but I would personally never go there, knowing what I know about the technique and things. He may have been one of the first to do outpatient spine surgery, but let's just say there was not much progress after that. And there's been tremendous progress in technique and results with other types of surgery. So Dr. Anthony Young, on the other hand, continued to progress over the years, develop new techniques, advance the field tremendously. And he's retired now, but I still stay in touch with him. And he's been very busy. We're very like-minded, Dr. Anthony Young and I. Our main focus is the patient and getting the patient well, like getting rid of their pain, getting rid of their leg pain, getting rid of the back pain. Many spine surgeons don't focus on the patient. They focus on what are called outcomes or metrics that they're taught that are important, not necessarily the patient's results, how the patient perceives their surgical outcome. For patients, they want to get rid of the pain. And as many of you out there know, you go to see a spine surgeon about a spine problem, they'll tell you that surgery can't fix the pain. They do surgery for other reasons, to stabilize, And many times it doesn't work to fix the pain because they're not actually treating the pain source, the source of the pain, because they don't understand the source of the pain. They don't know where it is. They can't figure it out. And then, of course, even if they figured it out, they don't necessarily have the best treatment for it. So the results are not going to be the best. But there are a few spine surgeons in the world that made the focus of their practice actually curing pain and have become very good at it. And Duke Spine Institute is one of those places where our focus is to cure pain. This patient right here we're doing surgery on, 22 years of back pain. I'll bet she's had it even longer than 22 years. But it's tremendously restricted her in her life. It's had a profound impact on her. She is a real go-getter. Okay, I can't tell you anything about her, but she's extremely motivated and very social person. And she's been living with this horrible pain for years and years and years in her back. And nobody's been able to fix it until she found Duke Spine Institute. And now here she is getting it fixed. Unfortunately, it's had a tremendous impact on her life and in ways that are not positive, okay? And the pain does that to people. It hurts them and it affects their quality of life massively. It affects their interpersonal relationships with other people. It affects their ability to perform their duties. It affects their dignity. And when you can't do what you want to do and what you're supposed to do to help, especially in a relationship, I mean, think about it. Human beings are social beings. We're all about relationships, okay? And in a relationship with anybody or an entity, there's shared responsibilities that you have to perform certain duties or services. Even going back to the first societies, hunter-gatherer societies, right? There are people who were responsible for gathering firewood. There are people responsible for going out and hunting and bringing home food. And anyone who failed in their duty failed the tribe or failed their social network at the time, which was primitive, of course. It's a tribe, but still it much more sophisticated than living in a cave by yourself. And so as human beings evolved socially over thousands of years, they learned to be codependent on each other, which means that there was the development of what are called divisions of labor and specialization. And certain people have certain responsibilities in a complex advanced society. And so how can you, when you can't do your job, when you can't contribute socially, you don't feel, as a person, you don't feel whole, you don't feel complete, you don't feel dignified, really. You lose your dignity. And so whether it's an intimate relationship with your spouse or children, loved ones, or it's a social relationship, more public, it doesn't matter. This disease of back pain, it robs people of their quality of life. It robs them of their ability to live with dignity and behave and conduct themselves and contribute. All right? So why do I dedicate myself to fixing people's back pain? Because number one, I can. At Duke Spine Institute, I can fix their pain. And number two, I think it's very important for people to be able to live without chronic pain, even though I myself don't have chronic pain. I mean, I am married, so sometimes I feel like I have chronic pain. But, I mean, not the same kind of pain that these people have with chronic back or neck pain. All right? Of course, I'm joking about being married and having pain somewhat. But that said, you know what I mean. So we're here to basically let people know you don't have to live with back pain anymore. You don't have to live with neck pain anymore. You don't have to live with thoracic pain anymore. You don't have to live with the leg pain anymore. It can be fixed. It can be cured. And it can't be cured everywhere. There are a lot of doctors that don't know how to do this surgery. And so it's going to take time for all of them to learn the technique. All right? It's going to take time for this technology to disperse around the world where it's available in every city. All right? But right now it's not. It's only available in a few locations. As a matter of fact, right now it's available in one. Eventually we're going to be opening an office in Orlando, Florida. There's the nerve root, by the way, right up there. Okay, and the herniation, we just got through zapping away. There's a little bit left there, which I want to get. Now, these surgeries are done with anesthesia. The patient is asleep and comfortable right now. But in the beginning, if you watch the beginning, you notice that she was not asleep. And that's because I need her help to make sure I don't get too close to one of those nerves. Now, I'm pretty good at not getting close to the nerves. I'm almost at a point where I can do it all without with the patient asleep completely. And if I had to, I probably could, and very safely. But my mentor, Dr. Young, who taught me a lot of this entry and approach technique, said that you should keep the patient awake to get their feedback. And I agree. It's important to do that. Go ahead. I am going to take 5-1 out since it was painless. All right. So, keeping the lumbar and thoracic patients awake for the positioning of the needles is, I believe, important. Plus, I get to do a discogram, what's called an evocative discogram. And an evocative discogram is really two procedures in one. Number one, I'm actually testing the disc to see if it's painful for the patient, because I don't want to be operating on a disc that isn't painful. Like today, we found the L5S1 disc was not painful. And so we're not going to do any surgery on L5S1. When I look at a herniated disc in the spine and I'm weighing whether or not to treat it in a patient, what I look for is a reason to treat the disc or a reason not to treat the disc. Just because someone has a herniated disc does not mean they need surgery. As a matter of fact, most people with herniated discs don't need any surgery done on those discs. That's because the discs have the ability to self-heal. You heard me right. The disc herniations have the ability to self-heal. The problem is they don't heal in every person. And there's a reason for that. But just for the simplicity of deciding what to do with a herniated disc in a patient, I would never operate on a disc that's asymptomatic. So the first thing in my mind is the disc herniation, whether it's small or large, is it causing symptoms? Is it causing signs? Is it a problem for the patient? So what are signs and symptoms? Well, symptoms are things patients complain about: back pain, leg pain, numbness, tingling, weakness, balance difficulties, dropping things. And then signs are things that the doctor finds by examining the patient, like a wide base gait, or positive Romberg, or Babinski, or clonus, or Briss reflexes, or weakness on exam. And I'm going to tell you right now, if you're going to treat patients with herniated disc, it's very common to have a patient come into the office and you'll ask them in the history, do you have weakness? And they say no. Are you dragging your foot? No. Okay? And then you do an exam and you find out they do have weakness. All right? And so if you find weakness on the exam that the patient doesn't complain about, does that mean they don't need treatment for that weakness? Of course they need treatment. That's number one. You're treating the patient, not just their symptoms, okay? So you need to know if they have true weakness or numbness, loss of feeling, loss of neurological function, okay? So how do you lose neurological function? There's two ways, Sean. You either have some disease has an effect on the nerves, or it has an effect on the spinal cord, or it has an effect on the brain. Those are the three parts of the nervous system. So to have neurological dysfunction in a patient, it either affects the brain, the spinal cord, or the nerves, okay? Now, when you're dealing with the spine, you're not dealing with brain problems, you're dealing with spine problems. So in the spine, there's only spinal cord and nerves, and specifically nerve roots. Those are the very beginning parts of the nerves. So what we really are treating with spine surgery is problems affecting the spinal cord or the nerve roots. They're called nerve roots. Okay? Very important. I can feel the herniation. It's huge. I'm literally pushing it. I'm going to push it back into this disc. And then I'm going to take it out from inside the disc. Okay? That's what we do. I'm just reducing it. Let's try to get her a little. I mean, are you happy with her? All right. She's not really responding, so that's good. Just a little bit. And I just don't want her clamping down. So I don't know if you can give her a little, huh? Yeah. Yeah. So what I'm talking about, if you're doing this type of surgery, is when I'm doing this part of the surgery, when I'm outside the annulus where the tear is, and I'm putting pressure on that part of the disc, that's the most painful part of the disc. It's going to stimulate the patient's brain, and it's going to want to wake them up. So not only does she want to wake up, but she's also reflexively moving her body like a little worm away from the area of pain. So if the pain is coming in on the left, she's going to move to the right. That's all subconscious, non-cortical reflex movements. Yeah. And, we're good? And I know it seems strange, but somehow we're able to suppress reflex movements, right, with anesthesia? How is that? Do you understand that mechanism? I don't. Huh?
Yeah, there's theory, so.
Is that what they call spinal anesthesia or something?
Yeah, I don't think so.
No.
Up and down cracks.
Shot. So what were you saying?
There's a local reflex at the level of spinal cord.
Yeah, it's true. So the reflex happens at the level of the spinal cord where the nerve roots go in. But there are cortical pathways that affect the reflex. They come down. They're descending pathways. And somehow those descending pathways are when the brain goes to sleep, like we want it to for this procedure, because we're using propofol only to put the brain asleep. When the brain goes to sleep, somehow it affects, what's wrong with the other one? Huh? Oh. Somehow, when the brain goes really deep to sleep, it affects the reflexes, and it shuts them down. It shuts them down. So I don't know if that's a brain stem or a higher cortical. Do you have it?
I think there's upregulation central down, upregulation reflex.
Yeah. So you think but is it cortical or is it brain stem?
It's a brainstem reflex that's being modulated, potentiated
Uh-huh.
by a more wave.
All right. So we have consensus between myself, the neurosurgeon, and the anesthesiologist that there's some fibers, nerve fibers that come down and affect the reflex loop. And clearly we've shut it down the deeper the patient goes into anesthesia, which is good for the patient and good for me because I want the muscles to be relaxed. I want her muscles relaxed. And when they're relaxed, the bones can be separated, spread apart, like I just did. And I can reduce the herniation back into the disc and then take it out safely from inside the disc. And that's what we just did. Shot? Yeah, that's beautiful. Beautiful, beautiful. All right. And now if the patient's more awake, then they're feeling that they get this reflex loop that causes the muscles to tighten, and they cause the bones to squeeze together. I don't know if you can see that, but they cause the vertebrae to squeeze together and close down on the disc, which makes my job much harder. All right, any questions from the audience?
We do have a question from YouTube.
Sure.
One of our viewers is wondering, how are these kinds of surgeries able to be done outpatient? And he mentions that he had a large surgery that he couldn't imagine being done outpatient.
All right, so I apologize, Sean. We can barely hear you. maybe just a little bit, 10% louder on the volume, because I couldn't hear your question. I just heard YouTube and the rest was garbled.
Is this better?
Yeah.
Okay. The viewer wants to know, how are these kinds of surgeries done outpatient nowadays? He mentions that he had a large spine surgery and he couldn't imagine it being done outpatient.
Yeah, we do your large spine surgery and even bigger, much bigger, outpatient. How? That's a great question. It has to do with more than one answer, more than one thing. It has to do with the way I do the surgeries, the technique I use. It has to do with the anesthesia and the control of the patient's blood pressure during the surgery. It has a lot to do with our ability to control pain post-operatively after surgery when you wake up and you're discharged. But if you go to, Sean will type the address for you, okay? Sean will type the address for you. It's the Surgery Center of Viera, and it's called Dancing Fusion Patients. Dancing Fusion Patients. And we actually have a link at the top of the page, and you can see literally almost 100 patients that we did fusions, really big fusions, like massive fusions. And they all went home within 2 to 3 hours after surgery. So we do it. And again, it's an anesthesia, a pain control, a surgical technique, a management of the blood loss. It's multifactorial. There's not one thing that does it. But we do a lot of things to make that happen. And we've never, ever, not once, had to keep a patient longer. They all go home. See, we're in Florida. The law in Florida says ambulatory surgery centers have to, that's a piece of herniation by the way, have to discharge the patient at midnight. So Florida has the strictest laws when it comes to sending patients home. They don't want patients staying overnight. They don't want patients being transferred to the hospital. We've never done a hospital transfer for any of my patients, ever. They've all gone home. And they all come in. Usually if they have a major surgery, they come the next day to the clinic and we take their drain out. We send the patient home with a drain in their back or neck, depending on what kind of surgery we're doing. And they empty the drain at night and they come back in the morning and we take it out. So we've been doing this for now almost 8 years and we've never had a complication. That is a piece of herniation right there, okay? And I'm zapping it with a laser. I don't know if I answered the question. I tried to, but if there's a specific question you have, go, Sean, post a link for the Dancing Fusion patients so they can see it. And then, you know, maybe, oh, if you get the app, whoever is asking the question, you want to see some really amazing fusion surgeries we do, outpatient, then download the Duke Spine Institute app. It's free. And just go to the surgery section and you can actually watch some of our archived live stream spinal fusion surgeries and see the massive surgeries that are done here, that they all go home. That's why we broadcast, folks, is so that we can educate everyone about the truth, about what's really happening at the tip of the spear in spine surgery around the world. We're not broadcasting to show you 50-year-old technology that, you know, is dead. We're showing you the most advanced, the most successful techniques in spine surgery available in the world. There is no place in the world that does better, more successful, less complications, faster recovery spine surgery than Duke Spine Institute right here in Central Florida. I'm not trying to brag. I'm not trying to advertise. I'm just telling you, if you want to watch the most advanced surgeries in the world, you tune in and we broadcast them every week. Now, we haven't had a fusion in a little while, but I will tell you this. Whoever asked the question, this is good. Next Tuesday, we are planning to schedule a 5-level lumbar fusion. That is as big as it gets. As big as it gets. It is literally, I think, L 1, 2, 2, 3, 3, 4, 4, 5, 5, 1, with osteotomies at each level. Those are called Smith-Peterson osteotomies. So we remove the abnormal facet joints And we do that to correct the alignment of the spine. We're going to be putting interbody cages at each level through a transforaminal approach, usually left side. And we're going to reconstruct this patient's lumbar spine. They had an injury to their lumbar spine where they blew out 5 discs years ago. And when those discs blew out, the bone started shifting around in the spine. And he's got stenosis with pinched nerves. He's got back pain. He's got bad deformity that's developing. And he also has short pedicles to begin with. So it's a major, major surgery, and that patient will go home 2 to 3 hours after surgery. You'll see them. Maybe we'll do another dancing fusion video afterwards, because we haven't done one in a while. I stopped doing them because, you know, we were just, every single patient was a success, and we just got tired of doing them and posting them. But that said, we'll be happy to broadcast the surgery next week. I think it's going to happen on Tuesday. I'm not 100% sure, but it's a surgery that we have planning on doing very soon. So it's either going to be next week or it'll be the week after. Sean, there's a schedule, right, that you could that you post that shows what surgeries are coming up.
Yes, the schedule is viewable on our live stream webpage.
Yeah. Now this patient here would have had the same surgery, okay, that is going to happen next week, but she chose to do the laser instead. Now the patient for next week, that's 5 levels, we tried to do the laser on that patient, but we failed. I could not get into the disc. And the reason is because his arthritis was so massive in the facet joints. They were 5 times bigger than normal. They were deflecting the needle, and I could not get into the disc. So he had a combination of several anatomical features that made it impossible for me to do the laser surgery on him. We tried. It was supposed to be a staged 3 separate surgeries over the course of about 6 weeks, and I could not get into the discs, period. And the reasons were, number one, very short pedicles with very big facet joints from the injury to the disc that created arthritis in the facet joints over years, which caused the facet joints to enlarge. That's why we have to do an osteotomy on him. And then on top of that, his spine was extremely anterior in his body. In other words, it was far away from his back, from the skin. And so to get into those discs, I couldn't get there because the spine was so far forward or anterior in his body. So combination of the facet joint enlargement, the short pedicles, and the very collapsed foramen and the very anterior spine made his surgery with the laser impossible. So when I talk about this surgery you're watching, the Duke laser disc repair, it's going to replace spinal fusions in the future, about 98% of them. That patient that we're talking about would fit into the 2% that it won't work for, and they're just going to need a fusion, decompression and fusion. But you're going to see, if you tune in next week and we do the surgery next week, you're going to see as big of a lumbar surgery as can be done in the world. You're going to see it all done right here, outpatient. All right, just wrapping up. This is the L3-4 herniation. I'm looking laterally in the disc. How's our irrigation? Stand by. Let me see if I can grab that. We have this disc, and we have one more, which will be L2-3, and then we'll be done with this patient. I think our next surgery is a 2-level.
Yes, sir.
I'm being told the next one is a 2-level. Just about done. You can see at 12 o'clock there, the red stuff and the tissue. That's called loose connective tissue and some epidural veins. And that is the top or most posterior part of the annular tear. And you can see this injury happened a long time ago. This material that I'm working on, this crab meat, is really, really scarred up. So what do I expect for this patient? I expect today when she wakes up in about an hour and a half that she's going to tell us her back pain's gone and her left leg pain is gone. That's what I expect. And why would the back pain be gone? Because we fixed her discs. Okay? We basically did a Duke laser disc repair to debride the annular tear. And still a little bit of herniation here, stuck down. And then the leg symptoms will be gone because we did what's called a decompression. We unpinched the nerve. Okay? We unpinched the nerve. She had bad stenosis, narrowing from the herniations. And now that's gone. Now we're well into the foramen. We're looking at the outside of the disc. That's where the herniation was. I don't see it anymore. It's gone. And standby laser. The nerve root should be right up here. There it is, that white thing. There's a little bit of fat to the right of it, but at 12 o'clock is the nerve root. And there's that collapsed disc right there. And it's just some bone spur there that's left. Okay, we're done here.
Lights on, please.
Just gonna suck out the irrigation. All right. Now, taking this tube out, we have one more to go. I'm going to apply some pressure. Actually, I'll do this. You go ahead and do what you need to do. We're going to bring the fluoroscope back in to navigate. The fluoroscope being the X-ray machine. It's a special kind of X-ray machine. It's not a standard X-ray machine. It has it's called a C-arm because it's an X-ray machine that has the emitter and detector all connected onto an arc at both ends of the arc. And the arc wraps around the patient's body so that you can take a shot through the patient with the X-ray machine, and you don't have to be fiddling around with detector plates and repositioning the patient and putting on plastic sterile sheets. It's literally one and done. It's one of the most ingenious applications of X-ray technology for spine surgery. Now, at Duke Spine Institute, we pride ourselves on safety, and in particular, in this case, radiation safety. So I will tell you that there are many facilities around the world that unfortunately use old technology with their X-ray machines, and the old technology and bad practice habits result in overexposure of radiation to the patient. All right, you need to move north. Are you pulsing? Good. And go north and, I don't know, try to narrow it up to the L23. We're done with every disc except for L23. So there you go. And maybe bring the bottom, close up the bottom as well so we don't have to see the sacrum. There you go. That will reduce the exposure to the patient and the staff. Perfect. Just leave it there. All right, so I was talking about radiation safety in spine surgery, and I can tell you that unfortunately it's a cultural thing primarily. It's really a cultural issue, and it's a financial issue. Okay? The newest X-ray equipment, the best top of the line, costs about $200,000 per machine. There's a lot of older machines on the market that are available for purchase that are running around $50,000 to $80,000. And unfortunately, a lot of doctors, they're looking to save money, so they buy the cheap machines. Well, those cheap machines many times are dangerous because they emit unsafe levels of radiation. Unfortunately, the machines that were built many years ago, they're not as safe as the newer machines they leak the X-ray radiation. And they've done tests, not here at Duke Spine, but elsewhere, where they found that those machines are releasing dangerous amounts of radiation on patients. Of course, that doesn't hit the mainstream media, so you don't know about it, but I know about it, and it's a major concern, to be honest with you. I don't want my patients being exposed to radiation at dangerous levels, and I don't want my staff being exposed to radiation at dangerous levels. So at Duke Spine Institute, we've invested in the state-of-the-art, top-of-the-line machines, and we have them checked every year by a physicist to make sure they're working properly. All right. But I can tell you there are a lot of places that don't do that because it costs more money. So it's a financial decision, or, you know, it's a philosophy issue. The doctors many times have no clue how dangerous the radiation is. Is that it? All right. So this patient, if she had her surgery done elsewhere, would likely get about 10 minutes worth of radiation. Easily. Is that the shot? How many seconds of radiation are we at right now? Huh? 1.5. 15 seconds of radiation. Right? Yeah. So, did you hear that, folks? I just talked to my technician. We're at about 15 seconds of radiation. We'll probably finish out. And part of that is I'm very careful to not ask for too much exposure. So the button pushing by the tech is at the surgeon's control. So the more the surgeon asks for radiation shots, the more the tech is going to push the button. And the more the tech pushes the button, the more dangerous it is for the patient. 20 seconds of radiation for this spine surgery is amazingly little amount of radiation. So we're keeping the patient safe, and I'm keeping my staff safe. And that's important. Now, a lot of surgeons don't think about it. How many spine surgeons that you've worked with over the years, what percentage would you say actually are very compulsive and worried about the amount of radiation during the surgery? Percentage.
Very small.
Like less than 5%? Less than 10%? What?
Less than 10%.
How many years have you been doing anesthesia for?
35.
35? So my anesthesiologist has been doing it for 35 years. He says less than 10% of the spine surgeons he's worked with over the years actually care about the amount of radiation they're exposing the staff and patient to. Okay? Now, why is that? Does the surgeon not understand the danger of radiation? No, they do. The reason is simple. They don't know that they can reduce the exposure. They don't believe they can. You remember the story of the little train, the choo-choo train that goes up the hill? What's that story?
I know you're saying, I think I can.
I think I can. I know I can.
The little engine that could.
The little engine that could. Okay? I read that book as a child, and it shaped my personality to believe that I could change the world in a better way. So, unfortunately, I can tell you, it's a cultural thing. A lot of surgeons don't believe they can make a change, make a difference. So they don't try. Now, they're correct to a limited degree. At the hospital, unfortunately, you can't buy a new x-ray machine. The hospital won't spend the money. But at Duke Spine Institute, since I'm the boss, I bought the x-ray machines. I had full control. I spent my money to do it. The difference is I took an initiative to change the way things were done. I grabbed the bull by my hands and I made it happen. So I got tired of being at the hospital and not being able to control the things that were directly impacting my patient and myself and my staff. And so I started the surgery center here where we could, there's a herniation by the way, where we could control everything. And now you see radiation times go from typically 10 minutes for like a 4-level procedure of the lumbar spine down to, 17 seconds, which is where we're going to finish this case at. You understand what I'm saying? And it doesn't stop with radiation safety. It also goes to, antibiotic and infection risk safety. So I'm able to use the types of antibiotics or infection prevention measures here at the center at Duke Spine Institute that I wouldn't be able to use at the hospital. Okay? So hospitals are always trying to, unfortunately, tell the surgeons how to do their job properly and do surgery properly. But the fact is, there's nobody in the world better than a surgeon who cares about their patient's well-being and has properly educated themselves with the truth and the facts. There's no one that's going to be a better advocate for patient safety than a surgeon who cares. Okay? And so, unfortunately, there are surgeons who don't care too, right? For one reason or another. I won't try to make excuses for them. But if you really care about your patients as a surgeon, you're going to want to control everything that happens to them while they're having their surgery, their treatment, and you're going to want to make sure it's the best for your patient. You have the best x-ray machine, the best staff, the best medications, the best anesthesiologist, the best. And when you put all those really good ingredients into the surgery, something amazing happens. The patients have great results, exceptional results, better results than anywhere else, because you have exceptional treatment for the patient. Anyway, we're almost done. And this disc, by the way, looking at this disc right here with all that soft billowy blue, and I mean this disc is, of the 3 discs that we've treated, it's the nicest one, the most normal looking one. Of course it's not normal looking, but it's the closest to being normal looking of the 3. This crab meat here is nucleus pulposus that's degenerating. And if it's healthy nucleus pulposus, it'll just be white, and it'll just stay there, and it'll be firmly attached. And so that's why I'm using the grabbers to see what loose pieces there are. Loose pieces are herniations that we just pushed back into the disc. So I don't want to leave any of those in there. They'll come out later, and we don't want that to happen. So it's kind of a very fine balance of not taking out too much, but not leaving too any. Look, there's the tear, by the way, right there. Look at the tear. Left side, right side, and look what's wedged in between. Okay, that's a piece of herniation. That's called the interposed nucleus. Now, different surgeons like to use different tools for endoscopic surgery. I like the laser. The laser, to me, is the most efficient and effective and safest way to remove these things. Other surgeons use radio frequency. And radio frequency generates something called plasma. Have you all heard of plasma? Spelled plasma, P-L-A-S-M-A. So plasma is just really highly energized tissue. And it has a similar effect to the laser, but I personally like the laser better. Some surgeons like plasma better with radio frequency, and that's fine. I'm not here to judge them, but I have my reasons for liking the laser, and I would never, at this time, I would never switch to plasma, ever. Not with the current plasma technology. This laser technology is better than plasma. Okay, it's more efficient. I think efficiency is important. I'm able to visualize its effects very well, which you can with plasma. But the laser delivers its energy, its therapeutic energy, mind you. Therapeutic energy is delivered at 0.5 millimeter past the tip. So you're seeing with your eyes the effects of the laser energy. You understand what I'm saying? And what I mean by that is there's no hidden effect that you can't see, because the effect of the laser is virtually on the surface. It's like a powerful stick, an energy stick. And whatever you touch with it just gets vaporized. So you can actually be extremely efficient and extremely accurate as a surgeon at what you're doing. You know what I mean? Take, for example, a scalpel. All right, this is the great discussion in medicine, and it's full of idiotic opinions of people who don't understand anything about laser. Scalpel versus laser. Okay? Am I a scalpel user? Of course I am. I'm a scalpel user. I'm a surgeon. We use scalpels, period, whenever we do surgery. I just used one today on this laser patient. Now, when you take a scalpel and you press the blade through the tissue, you cannot see what the blade is cutting once you get past the first layer of cells, which is called the epidermis. But the scalpel cuts through the epidermis and the dermis. You're cutting through millimeters, if not centimeters of tissue, and you can't see any of it. You're blind to it. But with the laser, you're peeling away one layer of tissue at a time. So if people want to talk about what's more accurate, the laser. It's more accurate than a scalpel. What's safer? The laser. It's much safer than a scalpel, as long as you use it properly. Okay, you can argue that some imbecile with a scalpel could do a lot more damage than somebody with a laser. It's true. If I had Dr. Jekyll operating on me, I'd rather he have this laser than a scalpel, trust me. He'd do a lot less damage. So lasers are safer, they're more accurate, they're even more reliable, to be honest with you. Scalpels tend to deform, they get dull. They can even get dull during a single surgery. And then you have to change the blade. And now you're creating waste. Now this laser doesn't create waste. So as far as being green technology, scalpels are not green technology, lasers are. Scalpels create a biohazardous waste that has to be dealt with very expensive measures, including, what is it called when you throw them in a furnace? Somebody help me? Incineration. Yeah. So when you have a box full of used scalpels, those are a danger and threat to your staff in the operating room and in the waste areas of the hospital where they deal with sharps, right? And then you've got to incinerate it. So then you have a risk and danger to the people that do the incinerating, plus you have all that wasted heat and energy to incinerate the scalpel blades. With laser, we don't have any of that. There's no sharps created. There's no waste created. There's no incineration. You just clean this laser fiber in an autoclave. So for those of you who listen to doctors talk about and badmouth lasers in medicine that don't have any clue what they're talking about, now you have a clue. And those guys are just bumping their gums about lasers. They have no idea what they're talking about. Laser is an incredible tool, and there's nothing like it. And I could not do this surgery without the laser. Impossible. Now, unfortunately, there's a lot of places that use the laser as a gimmick to get people to go there. And then they just do, you know, kind of surgeries that everybody else does, which are bad for you. I won't mention names, but I could tell you it's pretty much every spine institute except for Duke Spine Institute. Okay? So, these people lie to you and tell you they're going to use a laser. Well, guess what? You've watched me for the last hour use a laser. And that blue thing is the laser fiber. Okay? Let them show you their surgeries. And you'll see they're not using the laser. It's just a gimmick. It's called a bait and switch, in case you don't know what a bait and switch is. And unfortunately, these are surgeons and business people that are baiting and switching you. But we don't do that. Duke Spine Institute's all about transparency and honesty. We don't have any reason to bait and switch you. That's because its founder doesn't believe in being dishonest to people. We believe in honesty and integrity and professionalism in medicine. We're one of the few places still left that do that. And we want you to know that. That's why we broadcast live. We don't edit our videos. We don't hide anything from the public. It's all there for you to see with your own eyes and for you to hear. And we even give you a chance to ask questions during the surgery, which this would be a good time for a question break. Sean?
We don't have any questions right now.
I love it. The audience knows everything. How are we doing on irrigation? Because I'm starting to see a lot of debris. I know we're getting a little bit of bleeding from the wall. We're just about done. There's a piece of herniation right there. Right there at 12 o'clock, I'm zapping it. And that is actually in the kind of epidural space. It's at the end of the annular tear. Pretty cool. Oh, that's the last of the annular tear. Look at that. And there's some herniated discs sitting inside the annular tear right there. Let's see if we can grab it out. A lot of times the herniation is stuck to the annular tear because of the inflammation. Yeah, it's kind of stuck in there. Got a little bit. But that's typical. That's what we see all the time. I love these surgeons that go in and they show a picture of a herniation they took out that's the size of a baby's arm. And they're so proud of it. And it's like, great, yeah, but that's not really what happens normally. All right? So, but that's good. It's good that they show you that. It's kind of nice when you get to see a giant herniation, right? Because now you know what's been causing the problem the whole time, is that giant herniation. Unfortunately, getting it out, it rarely comes out as one big piece. And that's because the herniation is stuck down. Now, when you'll get those big pieces when it's an acute herniation. And I don't mean cute like, you know, the prom queen kind of cute. I mean acute as in it happened recently. Is that bad to say that anyway? No? Yes? Everything's bad to say these days. I don't want to offend anyone. I'm just kidding. If I haven't offended you by now, I'm sorry. I'll do my best to do so. Look, I don't believe in being discriminatory. I think everyone should be equally offended by my comments. And I'm laughing, but the truth is that when you produce your own show and you pay for it out of your own pocket, you get to be in control of the content. And you know, we want to make this obviously as educational as possible, but we also like to throw in a comment or two. Now I have to honor a request. We had a request to talk about vacations, okay? And I know it's coming at the end of the surgery, but we had a request to talk during surgery about vacation. So I will talk about vacation. The request came from someone who, I think she's been to Thailand, huh? Cambodia, sorry. Yes, Cambodia. And she was talking about how wonderful the trip was. So I personally have not been to Cambodia. I would love to go someday. That would be fantastic to do that. But that said, I have not been to Cambodia. So what are some nice vacation spots? Any suggestions from our audience? Since we're opening up this to a discussion on vacations. If you have a family and you like tropical, I would recommend the Caribbean. And there's a place called Beaches I've been to with my kids. It's wonderful. Very safe place. If you like scuba diving especially, it's the place to go. How are we doing on irrigation? Still good? All right. No, we're done here.
Stand by, buddy. I am actually, look 1 second.
All right, let me show you folks what we've done. And yeah. So the whole surgery is done with a metal tube. Can you see that? Let's get the scope off, please. It should not be on. Can you guys see the... Sean, did you show them the incisions?
Yes, we're looking now.
Yeah. I'm going to just put some pressure for a moment. There's no bleeding, but I like to keep pressure on every patient on the muscles because we're passing through the muscle. Would you mind holding this here? Just to show you what I'm talking about. If this is the skin, this is the dilator. The tip of the dilator is tapered, meaning that it narrows down to a point. And dilation of tissues in the human body during surgery is very old technology, a very old technique. But the use of a dilator like this in this type of surgery is somewhat new. But the concept is the same. The skin has a cut. You're not dilating the skin because I already cut the skin with a scalpel. But what you're dilating is under the skin as I pass down to the annular tear. So as I go from the skin surface to the annular tear, I'm passing through muscles. And the dilator spreads those muscles apart. It doesn't cut the muscles. It just gently opens the fibers, like spreading them apart. All right, so look, watch. See my bicep muscle right here? See the bicep? Okay. If I do this, I'm stretching the bicep fibers. If I do this, I'm bringing them back together. So the dilator does the same thing. It literally stretches the muscle fibers around the metal tip and the shaft as it penetrates into the disc. So you're not cutting the muscle fibers, you're dilating them. That said, I don't expect any bleeding, but you never know. I could be spot onto a vein and just touch the vein and rip it. And if that's the case and there's some bleeding in the muscle, I want it stopped. So the way you stop venous bleeding is with pressure, just putting pressure on the muscle. You need to put about 10 millimeters of mercury to 12 millimeters of mercury pressure. You're safer if you put 15 or 20. That guarantees that there will be no extravasation of blood outside the vein because the vein pressure is usually 12 millimeters of mercury. So if your counter pressure outside the vein is 15 or anything higher than 12, then you're not going to have bleeding until it clots. It takes 4 minutes to clot. Okay, I hope that you enjoyed the surgery. I've got a Raytech off. We've completed this lady's surgery and it's gone well. We've had literally 1 milliliter of blood loss, 1 mil. That's nothing. And we had about 17 seconds of radiation, which is, again, virtually nothing. Any questions? Nice work, everybody. Any questions, Sean?
We do have a few questions, but we can answer them on the face cam if you'd like.
Perfect. I'll be back there in about 4 minutes. Everyone hang on. This is time for a potty break if you want. I'll be there in about 4 minutes to answer questions. Yep. Yep. All right, I'm heading out to the other room.
All right, everyone, Dr. Duke will be joining us shortly in the conference room. We'll be getting on his face cam and he'll answer any of your remaining questions. If you have any still, type them up in the chat now. If you're looking on your screen currently, you can see the preoperative MRI that was performed here. The 3 levels we just operated on are the top 3. The L5-S1 we tested with a discogram at the beginning if you were watching, and it didn't elicit any symptoms, so we did not end up operating on the final level.
repairs with the Duke laser disc repair, endoscopic, transforaminal, and all 9 patients have had 100% elimination of their symptoms with the surgery. Today we just finished up a case where the patient has had really bad back pain in her lower back for about 22 years. I suspect it's been a little longer than that. She's never had anyone be able to fix it for her. Like many people, she's searched for answers and solutions to cure the pain and has always been told there is no cure until she found Duke Spine Institute. When I examined her and I saw her MRI, I knew she had a problem with at least 3 discs that were causing her back pain. That's the L23, 3, 4, 4, 5. And then the L5S1 was a smaller injury to the disc with a tear and a bulge. And I thought that was causing her pain as well, based on her exam. So we got her in the operating room today and we tested all 4 discs. And sure enough, the L23, the 3-4, and the 4-5 discs were causing her typical pain that she gets every day. And she had a 10 out of 10 pain at each one. The L5S1 disc, which was a much smaller injury, it had healed itself and there was no pain. So the L5S1 disc was a perfect example of how a herniated disc can actually heal to the point where there's no pain or symptoms as a result. And so we did test that and we found it was not painful. That said, we did finish the laser surgery at L23, L34, and L45. So I understand from Sean we have some questions.
Yes, our first viewer on Facebook is wondering, Dr. Duke, I was told that you can re-herniate when you get laser surgery, but not with fusion. Is that true?
Great question. So it's true and not true. Here's how it's both true and not true. With laser surgery that I just performed, the Duke laser disc repair, I want to make sure you can all see this. So I'll do my best to look and see. That's probably the best view right there. Okay, we can all see the herniation here. The herniation is the jelly from the center of the disc that's squeezed out through a tear. If the tear wasn't there, the jelly would never come out. Now, when we do the Duke laser disc repair, I come in and I push this with the dilator, I push the herniation back inside the disc. And then I take it out from inside the disc, blend it up basically with the laser, and then remove the fragments. And then I'm left with that tear, right? So the Duke laser disc repair is the only surgery in the world where we actually use a laser to clean the tear up so it can heal now. Now the tear was trying to heal all those years that this patient had their herniation and back pain. In her case, it was 22 years. But the tear was never able to heal and close off because the jelly was stuck in there. That jelly right there was wedged into the tear. So the tear is trying to close, but it can't because the jelly's stuck in there. So I zapped away the jelly and I cleaned the edges of the tear. Now, after the laser surgery, the tear is not healed. It takes literally about a year to fully heal over and get strong. So in that first year after surgery with the Duke laser disc repair, if you do something like bending over or lifting something heavy or even twisting the wrong way, more jelly, a piece of jelly can squeeze out through that unhealed, weak tear until it's completely healed, okay? So what's different about a fusion? Can a fusion reherniate? The answer is this. If the fusion's done at a disc, say 4-5 disc, okay, this disc right here, you won't typically reherniate at that disc, though it can happen if the surgeon doesn't take the disc out. All right, then you could certainly get a herniation there. So situation number 1, the surgeon doesn't take the whole disc out. So you can get a reherniation at the level of the fusion, especially if the fusion doesn't take and the bones are moving and they can push out another piece of disc. That happens in a failed fusion or pseudoarthrosis. There are many people with failed fusions. Unfortunately, at least probably a good number would be somewhere around 25% of fusions don't fuse, and they fail to fuse, so they could potentially reherniate. The second type of reherniation you can get in a fusion situation is if I'm fusing these 2 bones together, this disc is being fused, people can get another herniation at the level above or below. The level above or below the herniation, below the fusion, can herniate. and we call that adjacent segment disease. And probably about 20%, on average, 20% of fusions of the spine result in herniations above or below the fusion called adjacent segment disease. Now that doesn't happen in Duke laser disc repair, the laser surgery, because we're not changing the biomechanics of the spine in such a way that it would put additional stress or force on the discs above and below the fusion. Fusions change the biomechanics of the spine. Once you fuse a segment, it can no longer move. It becomes very stiff. And so the fuse segment doesn't move, but the segment above and below the fusion does move. You can see the disc moving here and the disc moving here. So when you fuse L4-5 disc, it doesn't move, but the discs above and below move, okay? So you can get a herniated disc above or below the fusion. Next question.
That was our last one.
That was the only other question. I hope you enjoyed the surgery. I think it went really well. And yeah, we'll be starting another surgery in about 30